All right, welcome everybody to this afternoon's PSPN Primary Spine Provider Network webinar. This is part of the webinar series that we put on, which is a monthly members-only event. And today, my name is David Payton, chiropractor from South Africa, working with the Primary Spine Provider Network. I'll be hosting today, and we are privileged and honored to have Brendan McCann today. He is a chiropractor and primary spine practitioner, certified from the University of Pittsburgh. He did his chiropractic training at the New York Chiropractic College, and he practices out of Maine. And he also is the president of the New Hampshire Chiropractic Association and is a House of Delegates member at the American Chiropractic Association. He is sharing his screen. We're getting ready for the presentation. And just a little tidbit of interest is that as part of his work with Cape Integrative Health in Maine, he is developing care pathways specifically relative to hypermobility related disorders. So that's a good segue into today's presentation. Brendan, thank you so much for joining us.
Yeah, thank you for having me. I'm really excited to be able to talk here today. Yeah, so it's true. The hypermobility niche has been an interesting one to fall into in the past few years here. I received a diagnosis of hypermobile EDS, explaining a whole bunch of various multi-systemic symptoms that I was having at the time. Since then, as soon as I let patients know that I knew what I was talking about, word got around quickly that I was willing to work with people with connective tissue disorders. And so I've had to learn more and more and more about the various comorbidities and nested problems within the world of hypermobility. And upper cervical instability is one of them. It's interesting reflecting on some of the things I've been very judgmental about with chiropractic claims in the past. And I think that perhaps this is the subgroup that those chiropractors are seeing a lot of, that washes out when we look at the general population. But a better framing of what patients we're talking about really can make a big difference, as as we're all inclined to in the PSP model. Subgrouping is useful, and recognizing what you're looking at, diagnosis, is useful. And so we'll go through a little bit of that today. Upper cervical instability is the topic of concern that we'll chat about today. And it's the modern term used that used to be encompassed by both CCI, or craniocervical instability, and AAI, which is atlantoaxial instability. From our perspective as a primary level provider, the difference between AAI and CCI just simply doesn't matter. And so it's most efficient to just term it upper cervical instability, or UCI. And that's the direction that the literature is going as well. We can see that, we can see upper cervical instability occurring most commonly in the sagittal plane, usually with flexion as the most problematic issue. As a just clinical pearl, there can be some interesting responses when we try to use a McKenzie approach in these patients. Oftentimes we'll get symptom reproduction or symptom changes, but there certainly won't be that painful end range barrier that we would expect in a typical McKenzie situation. But yeah, so sagittal plane is the most common direct plane of instability in the upper cervical spine. Although we occasionally will see either unilateral or bilateral instability, and rarer still rotational. Axial instability is an issue as well, which is termed cranial settling. And that is a little bit more difficult to diagnose on imaging, just because that plane is, it's not easy to prove that there's movement happening there. And that one is oftentimes, from my experience, best described by the surgeons who see it regularly. Upper cervical instability typically associated with rheumatoid arthritis. That's likely the first thing that most of us think of when we hear upper cervical instability. There's a really robust literature on that management because it's considered one of the most severe outcomes in rheumatoid arthritis. And generally when we see that, it's monitored until it becomes a surgical issue because of the progression of bulbar symptoms or other lower brainstem symptoms as the dens gets compressed into the brainstem. And that tends to be an axial change as the skull settles down on top of the dens. Trauma and motor vehicle collisions are another obvious source of upper cervical instability, but I'm not going to talk about that very much because that would typically be managed in a trauma setting, and I don't think any of us are practicing in that setting here. It's also not, not going to be a subclinical diagnosis. It's that's an unstable injury. It'll generally be diagnosed on CT and be managed with fusion. What we are most commonly going to see in primary practice is symptomatic generalized joint hypermobility as our predisposing factor for upper cervical instability, and that's in the hypermobile population what I end up seeing regularly. So these are patients that generally will come to me knowing or suspecting that they are generally hypermobile. And the symptoms that will cue me to look at upper cervical instability tend to be widespread pain, headache and facial pain, eye twitches, tinnitus, symptoms of multiple cranial nerves, cervical radiculopathies, which for some reason seem to be most commonly T1, perhaps a neurodynamic or a nerve tension component to that, and as well as dysautonomia is a really common symptom in people with UCI. Interestingly, there is an old diagnosis called cervical craniocervical syndrome, which also in the literature, chronic allergic symptoms are associated with. Now, whether that's a comorbidity or an upstream or downstream effect relationship there, really an interesting question going forward. But not something that I've seen mentioned since the 80s in any of the literature. Let's see. So it's noted in the literature that there is a lack of high-level evidence articles around upper cervical instability. The chart on the right of the slide here shows the number of publications relative to UCI over the past few decades. As you can see, in the early 2000s, publication on it really spiked and tailed off in the 10 years after that. Although I think that what we'll see is that there's a real spike in publications in the past 5 years since this chart was published. The recognition of connective tissue disorders, heritable connective tissue disorders, is up. The recognition of dysautonomia is up. And I think that we're going to see that in our clinics more and in our educational systems more and in the literature more. From a symptoms perspective, an important thing to note is that this can be really tough to recognize, diagnose, and pin down because of the transient nature of some of the symptoms. Because of the nature of instability, we can have symptoms that are positional. That might be that there is a delayed onset of symptoms after a patient has had their head down for a period of time that once they've driven to your office and they've been in a nice neutral cervical position for 30 minutes, you may not be able to see symptoms. I haven't had that experience too much. People generally aren't quite that labile, but certainly the transient symptoms drive more siloed specialists crazy when the patient can't bring the symptoms into the office. It makes our review of systems and our medical history really, really important for diagnosis like this. Let's see. So a couple on the symptoms front, a couple of things that I've noticed are that there may be a tendency towards pain, neurological pain down one side of the body. This is something that I can't explain but see regularly. So we'll see like cranial nerve symptoms of one side of the face. We'll see a cervical radiculopathy on the same side, and we'll see a lumbar, intermittent lumbar radicular pain on the same side. The nerve tension tends to be there. I can't explain why this like hemi-global pattern exists, but that's something that I've seen with a few times a month. And another big clue tends to be the overlap of different groups of these symptoms, whether that be cervical radiculopathy plus cranial nerve or multiple cranial nerve involvement. These things that can't be explained by a single mononeuritis. So we want to think about when we're considering hypermobility. It's very easy to screen, when should your mind go down these pathways. If your patient comes in, their musculoskeletal injury history or pain and injury history is very extensive, or they have multiple orthopedic surgeries, and you happen to notice that as you're going through spinal ranges of motion, or just incidentally noticing that they're hyperextending their elbows or knees as you go through the exam. Perhaps they stand up and their knees immediately go into hyperextension. These are all clues that you may be looking at a patient who has generalized hypermobility, and you can use the Baton scale as a way to screen for generalized hypermobility. Now, just as a disclaimer, the Baton score was developed as a population screening tool, and it really was never validated for the diagnosis of generalized joint hypermobility. So it is a very imperfect tool, but it's a good way to screen in general and get an impression of whether your patient has generalized joint hypermobility. It tends to be a little bit dominant with like hand hypermobility. So if you have shoulder hypermobility and hip hypermobility, it's going to miss that. But you could then have non-hypermobile hands and look like you're not hypermobile according to the Baton score. We'll go through that in just a second. Very easy to go through a Baton score as soon as you start to make the suspicion. And then in 2017, diagnostic criteria were published and have been created into a nice PDF format by the Ehlers-Danlos Society. And these criteria can help us to move our diagnosis from a generalized joint hypermobility, which from the ICD codes would just be called hypermobility syndrome. It can help us establish that the criteria are there to make the clinical diagnosis of hypermobile Ehlers-Danlos syndrome. Let's say, hypermobile Ehlers-Danlos syndrome and hypermobility syndrome are the most common heritable connective tissue disorders. Now that I'm seeing a lot of people with connective tissue disorders intentionally, I have seen classical EDS, classic-like EDS, vascular EDS, Marfan syndrome, Loeys-Dietz syndrome, and type 1 osteogenesis imperfecta. But they're rarer, although they're not as vanishingly rare as some of the other Ehlers-Danlos types. There are 13 subtypes of Ehlers-Danlos. The differential diagnosis between connective tissue disorders could be its own lunchtime presentation. So I won't go into that today, but just know that the most common by just entirely by far is HSD and HEDS. In a population study in Wales, prevalence was estimated among primary care visits to be 1 in 500, which means that like these are patients that you're certainly seeing in your office, and prevalence has been seen to be pretty equal around the globe. So the Baton scoring system is our way of is our just nice down and dirty way of getting an impression of generalized joint hypermobility. And so it's a 9-point system. In people under the age of 50, 5 points is a suggestive score for generalized joint hypermobility. And in people over the age of 50, a score 4 or more is suggestive. The illustrations here show the different parts, joints that we're screening here. But just to see it in motion, we're looking for can the thumb be touched to the forearm? And that's 1 point for each side. Can the pinky be extended past 90 degrees? And that's 1 point for each side. Does the elbow extend past beyond straight? And that's 1 point for each side. Do the knees extend beyond straight? That's 1 point for each side. And from standing, can the patient bend forward and put their palms on the floor? And that's 1 more point. In my case, my score is a 5, and some relevant pieces here are when I bend forward, I don't look hypermobile because I can't get anywhere near the floor. Probably a function of sciatic nerve tension. And also my thumb is a positive on one side and a negative on the other side. And this is not uncommon. In my case, it's secondary to a sprain a couple of years ago. Never gained back that full range of motion. And that's why the minimum score drops as we go through life. If we're getting subtle about it, there's also counting people's historic scores is totally a legitimate way of making the diagnosis. If they clearly, I can clearly say, yeah, I could have touched my thumb to my wrist 2 years ago. In the diagnostic criteria for hypermobile Ehlers-Danlos syndrome, that can still be counted as a positive score. There are also other scales that we can use for establishing generalized joint hypermobility. Some people have a tendency to all distal hypermobility. Some have a tendency to more axial and trunk hypermobility. And so there's like 7 different scales that have been validated for that kind of use. Let's see. So when we actually get into upper cervical instability, we first want to think about the patient that's in front of us before we even get into our exam. The paper on the physical therapy diagnosis and management of upper cervical instability by Russick et al. Great paper, actually really one of the most clinically helpful papers that I read last year in the world of hypermobility. They suggest classifying patients into 2 scales. One for sensitivity or lability of their symptoms, and the other for severity of symptoms, high, intermediate, or low. And so patients who are high severity symptoms or high sensitivity symptoms, very labile symptoms, they're people that are going to have a lot of contraindications. You're not going to want to do provocation testing with them. You're going to want to make your diagnosis based more on symptoms and based on observation. I've seen one highly sensitive person. In this person's case, I asked them to just show me their neck range of motion, and they immediately had a vasovagal response simply to turning their head to its end range. In retrospect, she reflected that she knew that was going to happen, but she thought I knew that was going to happen. So remind your patients to be mindful and to communicate with you about these things. If you tell them to do something and they know that it's going to be overly provocative, let them communicate that to you for sure. and that can guide what you're doing in your exam. In this case, we want to go through the same neurological exam that we've practiced as primary spine providers. The 5-minute neurological exam that's in the CRISP books and in the PSP coursework for PIT. Very useful. I've picked up a lot of relevant information from just simply doing that thing that has been documented to be done many times prior for these patients, but they say has not been done. And this is often how we'll pick up things like multiple cranial nerve involvement. So the most common, I'd say, is probably symptoms of the trigeminal or facial nerve, glossopharyngeal nerve, and accessory nerve. Lower brainstem, of course, being closer to that area of high mechanical stress in the brainstem and the upper cord. And so those tend to be the areas that I see things in my exam. For example, I had somebody a couple of weeks ago who came in, they said they've been working with their speech language pathologist on their vocal cord induced exercise intolerance. What we found in this person was on their cranial nerve exam, their uvula swung to the contralateral side, suggesting glossopharyngeal nerve involvement, if I remember correctly. And the palate was lower on one side. And they also had some sensory changes in their face to cotton and pinprick. So these basic things can really pick up a lot. This is a group where you can actually get a little practice seeing abnormal findings in your cranial nerve screening. Interestingly, in that person, her symptoms were abolished if I just had her go into a little bit of cervical extension. So if she extended, her dysphagia went away, and she was able to get her vocal cords functioning normally. That wasn't something anyone had tested yet. And it sort of reflects on the positional nature of these findings. Let's see. When we go into our ortho or our provocative exam, I actually take some issue with the literature on the ortho exam for upper cervical instability. It's been done by expert consensus, and so the tests aren't well validated in a lot of cases. There are a bunch of named tests that, as I look at them, there's like the sharp purser test, the alar ligament test, vertebrobasilar insufficiency test, which, as we've talked about in prior lectures, that's one that's been shown not to be reliable, or the transverse ligament stress tests. I find that like these named tests basically are all just looking at positional provocation, stress provocation. And so we can really simplify our thinking by just saying, do positional stresses of the upper cervical spine bring on neurological symptoms, pain symptoms, or the patient's familiar symptoms? And so the passive sustained cervical positioning is how I term that in my notes. I'm really just taking the patient into rotation, having them hang out there for a few seconds, and seeing if it's provocative. I'm doing this with them lying supine and just doing it passively, which was consistent with how some of these other tests, like sharp purser and whatever, were performed. So most commonly, what I'll see on my exam is when I put them into passive flexion, there's some threshold that when they pass it, they get symptoms, whether that's facial symptoms or headache symptoms, dizziness symptoms, tingling in the bottom of their feet, low back pain, and or even nausea. So we'll find that the deep flexion brings that on, and then if we go backwards past that threshold, we can really find a spot where that instability kicks in and creates symptoms. One of the in the sharp purser test, which I believe is translational stresses, regardless, they suggest palpating the craniocervical junction and seeing if there is a gapping that occurs at the time that symptoms come on. And actually, I kind of like that suggestion. It's reminiscent of the interspinous gap change test that we learned for the lumbar spine for looking for spondylolisthesis. And so especially when it matches up with symptoms, that can be quite validating that the symptoms are coming from that upper cervical instability. In manual cervical distraction, what I typically expect to see is that distraction, and I generally do it either seated or in supine. We generally expect that traction to be palliative, even if it's just of local neck symptoms. Of course, the unstable facet joints will generally be sore, and so that traction feels great. A lot of these patients love it, although some of the ones with more nerve tension, that will actually be provocative. The meanwhile, axial compression will also be provocative, and in people that have diagnosis, surgical level upper cervical instability, I've seen that brings on pain from the COC1 joints, which may refer to the throat, to the occiput. Those are really the two spots that I've seen it, but they've described it as a lump in their throat or pain in the back of their throat. And oftentimes that's a familiar pain that they haven't mentioned prior. And then lastly is the grip release test. This is an interesting one that I've never seen positive, but I'm told can be. You're just checking for grip strength. Upper cervical instability tends to lead to low grip strength, shockingly low grip strength. And oftentimes, according to the literature, if they try to quickly then open their hands after sustained grip, the hands will cramp up. Haven't seen it, but that's what the literature says. And then lastly, doing a cervico-ocular exam can be really helpful. Oftentimes in the hypermobile patient, there are neck pain, they have neck pain, they have dizziness. Oftentimes the cervico-ocular reflexes are worth examining anyway. But in the patient with cervical instability, that positional nature may be seen in the cervico-ocular reflex findings as well. So two qualifications here are, one, you may see that in their position of stress, they're positive for oculomotor dysfunction, and in a more palliative position, that dysfunction may go away. And then the other piece is that a lot of these patients, as part of their autonomic symptoms, will have postural orthostatic tachycardia syndrome. And for them, they may, in a sitting position, have oculomotor dysfunction that then goes away once they've been lying for a minute or two, because, or at least the understanding is, because they don't get adequate blood flow to their brainstem in an upright position, and then that returns when they're lying supine. So there's a ortho exam colored by my experience. Here's one that I haven't put my imprint on at all here. The radiographic exam is really well documented. The paper by Lowcamp that I've linked at the end here is really, really good. One of my radiological colleagues brought it to my attention. And so we have really good objective measurements on imaging to reflect upper cervical instability. So climaxial angle is what I find to be the most interesting of these. And that's the one illustrated with the red lines in image A here. It's looking at how much mechanical stress is occurring at the anterior of the upper cord and brainstem. And so the protocol that I use here at my office is we'll do neck x-rays here in the office. And in order to pick up that dynamic component to these symptoms, we'll do an APOM view, a lateral neutral view, lateral flexion, and lateral extension. And importantly, when one of those positions is their provocative position, if they can tolerate it, and we always have this conversation, I don't want to put them in that position, have them hold that position if it's going to, if they're going to have a vasovagal response right there in my office. But if they can tolerate it, I do want to have them go all the way to where those symptoms are provoked, because that may pick up any mechanical movement that wouldn't otherwise be found in a mid-range movement, especially. This is one reason that upright MRI has been falling out of favor, is because oftentimes they won't be put in a provocative position and will get a false negative for upper cervical instability. Upright MRI has previously and intuitively been thought to be a useful modality of imaging for upper cervical instability, and certainly it can be, but the surgeons around me that deal with this are moving away from that because of unavailability of upright MRI services in certain regions. Here in New England, there are no facilities that offer that. And two, because of low quality of the images from upright MRI, just by the nature of the physics of it. It tends to be like a half a Tesla. And most surgeons would prefer a supine MRI plus an orthopedic exam, and having high quality images instead. So clival axial angle, as I was saying, is going to is a fun one to measure, because in neutral it should be between 145 and 160 as our average range, and then in flexion we should see that decrease by less than 10 degrees, and in extension we should see it increase by less than 10 degrees. If the neutral positioned clivoaxial angle is less than 35, that's a surgical consult indication right away. If flexion brings them under 35, that I would send that person for a surgical consult as well. And if their angle changes by greater than 10 degrees in flexion or extension, that could be worth a conversation. It might be that they never really are in those positions. They have very low risk for being in those positions, and it is an unlikely way for them to provoke symptoms. So it might not be, going through an invasive surgery over something that's unlikely to provoke might not be worth the consult. But particularly if we see that clivoaxial angle drop under 135, that's a pretty good reason for a surgical consult with somebody who has experience in upper cervical fusion, particularly if they have experience with the hypermobile population. The Harris measurement is the next measurement, and it's another way of, again, measuring mechanical stresses on the anterior of the spinal cord. It's from a line drawn along the posterior C2 up to the basion, and it measures the impact on the dura from that dens. The Grabmap stone oak measurement is similarly going to measure the impact from the dens on the anterior cord and dura, just this time in relation to the basion. And then the ADI and BDI, the Atlas dens interval and the basion dens interval, can reflect again in different axes instability outside of the normal range. And I'll show you the data that I've collected from my patients. The highlighted findings are the ones that meet some sort of abnormal indication. And so as you can see, cervical clivoaxial angle in extension on X-ray being higher than normal is my most common positive finding. And that's not a surgical indication. That's a conversation to have with the patient. Like, extension is provocative for you. You're outside the normal range. We would expect this to be provocative. Let's minimize that. I've had from this set of data, I've had two patients that I sent for surgical consults. One of them, we found a Chiari malformation on her neck MRI, and the other had several findings. One was craniocervical settling. One was the absence or stenosis of the vertebral artery on one side, and she also had facial cranial nerve symptoms through most of her cranial nerves, as well as dysphagia and dysautonomia. There were a lot of symptoms there. Shockingly, this is a patient who I had been seeing for a long time before I had this knowledge. Her facial symptoms actually improve with cervical manipulation. We were doing mid-cervical manipulation prior to any of this being on my radar, and when she was less symptomatic. But to this day, her facial pain still improves with mid-cervical manipulation. And after a long conversation about risk, she said, my pain is such that I would like to go ahead with that relative contraindication. Great learning case for me, very patient and very communicative. But she is scheduled for a surgical consult with one of these experts in Providence, Rhode Island next month. When it's not surgical, that's where we shine. As you can see from this data, most of these patients are not surgical. Their clivo-axial angle doesn't reflect an ongoing mechanical threat to the brainstem. The level of instability as they move through different positions is not such that it represents like a structural threat. And so this is where all of us shine. We can take an education approach and an active approach. Patients with upper cervical instability are going to improve if they know what positions provoke and relieve their symptoms. It's just like calming down any other nerve, essentially. And they're going to improve with better coordination of their neck, better proprioception in their neck. They're going to improve with decreased fear about movement and position and activity. They're going to improve if we address comorbidities. And so going through a really good review of systems to find ways of offloading stresses. Some of my favorite nerve pain work was done by Jeffrey Bove, and reflects that a nerve needs both a mechanical and a chemical insult in order to really manifest symptoms. The chemical insult predisposes mechanical hypersensitivity. And my suspicion is that in these non-surgical cases who clearly have neurological symptoms, my suspicion is that that's what we're seeing, is that some sort of source of chemical stress, like an unmanaged upper respiratory allergy or an unmanaged chronic GI issue, which is very common, something like that is creating an inflammatory, chronic low-grade inflammatory environment that induces this mechanical hypersensitivity. So addressing those comorbidities becomes super, super important. And then being able to position themselves in tolerable and palliative positions can be somewhat dependent on proprioception. And so building up some movement awareness is very, very helpful in these patients. The more they can get their symptoms calmed down, the more active they can be, the more they can build muscle mass to control that moderately unstable craniocervical junction. So that's really the direction that we have a big opportunity to go here. This is my, there's, as I mentioned before, the literature isn't super robust, but there is a growing literature. Here's the database of literature that I've gone through so far. Happy to send papers along. In particular, the two that are linked here are excellent. And I'm working up in Portland, near Portland, Maine, at Cape Integrative Health. You're welcome to connect with me on various forms of social media or by Gmail. Don't friend me on Facebook. I only use that for people who I would text baby pictures to. And thank you all for being here. I'm happy to take any questions in the last couple minutes that we have here.
Brendan, thank you. Fantastic presentation. I'm just going to quickly post into the chat there the 5-minute neuro exam that you referenced. So that is available for PSPN members on the PSPN. You can log in and access that there. I also did load it up on our YouTube channel as an unlisted video, so you can click that link and review that over there. Good stuff. Any questions from the attendees? Feel free to fire them away in the chat. Otherwise, Marsha, over to you. Do you want to make any comment?
Yeah, well, first of all, thank you very much, Brennan. I thought that was excellent. It really struck me that this is really a subspecialty within the PSP specialization, and the knowledge base obviously is deep. And I thank you for pointing out a couple things. First, the utility of a lot of the tests and measures that are classically used with patients that present this way. Their general lack of utility, if you will, and your kind of pragmatic approach to assessing the patients, and also for pointing out the importance of the neurological exam and of conducting that exam thoroughly, because it's not only for screening purposes, but also to establish a baseline. So my question is more, I'm thinking about these patients that typically, how they find their way to your office, I guess. I'm thinking about the clinical pathway and how these patients have probably been to a lot of other providers, and they probably have mixed conceptions or misconceptions about what may be going on. So do you, I guess, a couple questions is how they find their way to your office in the first place, and how you manage that, given that these patients are probably told a lot of different things by a lot of different providers.
Yeah, a lot of them are quite perceptive that people haven't really put the picture together prior. Of course, we know from the spine world in general, people like to stick to their specialty silos, and the patients know this too. So if you can, it's to me, it's really the review of systems in this whole process that puts things together, because the patient may come in to see us, the primary spine practitioner, for neck pain, or radiculopathy, or headaches and facial pain. Like, it could be treated as a very discrete complaint, but on the review of systems, we may see that it's part of a much broader picture, in the context of GI and allergic symptoms. And incidentally, those are two specialists that I refer these patients to a lot. In the conservative management of these patients, not really much has been written about the medical management of this. There's a robust literature on the surgical management, and there's an emerging literature on the rehab management, but medical has not really been considered very much. But we tend to see a really big improvement in these patients when we just decrease the overall allopathic load. It's possible that that these mechanical sensitivities are even secondary to some other systems issues. So I co-manage with allergists and gastroenterologists a lot for these patients. Ironically, I use neurologists less, but when I have used neurologists, it's primarily for comorbid migraines, or for my most severe patients. I found one particular practice that just does a great job communicating with them, and that the patients like working with. And so that's sort of where, like, knowing your local network is really, really helpful. As for how the patients are finding me, in my case, once I felt reasonably comfortable with the knowledge base here, I put myself on the directory for the Ehlers-Danlos Society, and people started finding me there, and then word of mouth spread. Here in Northern New England, there's only like one other person that will reliably evaluate for hypermobility related disorders. And the wait for these sorts of complaints in Boston is really long. Patients oftentimes are asking for an evaluation of Ehlers-Danlos syndrome, and in their primary care office and in other specialists' office here in Maine, they're saying, that's not our specialty, we don't do that. But they're getting that from every specialty. And so when I make the referrals for co-management, I think it's really important to emphasize that I'm not referring them for co-management of Ehlers-Danlos syndrome. I'm managing them for the I'm referring them for the co-management of the symptom. So of the migraine,
Okay.
of the tachycardia, of the chronic diarrhea, whatever, we're putting the picture together here in the office as a good primary provider would. We're putting the picture together here, and we're making a referral to the specialist that is accessible to that specialist. Give them something really actionable they can work on.
Okay, thank you. Yeah. So I just one more question quickly, but I'm kind of interested in how you guide the patient through exercise intervention, and what are some of your guidelines with actually prescriptions, exercise prescriptions with these patients? Because you mentioned, this level of irritability, for example, and their stability of symptoms. I'm assuming those are guideposts.
Totally.
And also, fear of movement. I would expect a lot of these patients have a lot of fear of movement, and how you kind of, get them to buy in, I guess, to the program. And
yeah, I think that the skill set is very much like the general population, but just at a different level of ability. So like the same foundational principles, like finding a tolerable way in, finding an accessible way into movement for them. That is the biggest one for breaking through fear and making them feel like they actually are able to do something. And with some very practical modifications, like, if I'm doing any sort of manipulation, whether that's soft tissue manipulation or joint manipulation, less force is going to be needed, more range of motion is going to be needed. So some of these very on the face of them kind of obvious things. So if we're often going to need to strengthen them through the whole range of motion. In fact, there have been studies on the hypermobile shoulder that showed that strengthening through the whole range of motion was really important for the best possible outcome. Whereas historically, there was this inclination to only train within the range of what a normal joint would do. But we can't make these joints be normal, so we need the patient to be strong through their full range. The key is making them aware of that full range, and encouraging them not to stretch into additional range. We're not looking to build extra, but these patients really will seek proprioception because theirs tends to be poor, whether that's as a downstream from a neurological insult or downstream from intrinsic fibers that basically go from slack to maxed out and never get that graded proprioception that they would in a good quality collagen construction. So there's some very practical modifications. I made a list of, so I tell the patient, this is going to be very individual. You and I can figure things out together. Those are both messages that they respond really well to because they haven't heard it a lot in the past. I also tell them, we're going to play it very conservative. So if it feels like we're going too easy, don't be surprised at first. We can always do more next visit. We can't go back and do less. Oftentimes there will be this inclination to post-exertional worsening, whether that's because of muscle inflammation or muscle release of cytokines, or because of neural ischemia or whatever. There's a million different mechanisms that could potentially be behind it, but post-exertional malaise is really common in this group. And so we like to be very individualized, very communicative, and very conservative at first. But a slow and low approach is going to be helpful for strength and coordination anyway. So really, there's a lot that can be offered even without a lot of specialty knowledge around this, as long as you're communicating with your patient.
Brendan, how do these patients typically respond to traditional weightlifting?
If we can get them, so some of them, honestly, so I actually had somebody the other week who's himself a clinician point out to me, none of this was really a problem for me until I got deconditioned. So he developed a cervical myelopathy, lower cervical myelopathy, and went through surgery and then went through a revision. And so he was basically deconditioned for about 18 months, and developed a lot of his autonomic symptoms and exertional intolerance during that period. And so he had to be incredibly consistent, incredibly patient on rebuilding his, not even fitness at first, just his movement tolerance at first. Some patients that are either the high severity, highly labile symptoms, they may start with like less than a minute of challenging movement per day. And so obviously the ability to be off from occupational challenges is helpful. And many of these patients actually are disabled. So there are a lot of socioeconomic or social determinants of health that really play a big role in it. My clinician patient was able to take a year off from work, and then work on this a little bit every day, very consistently, very patiently. But that's not something that everybody would be able to do. Granted, those aren't likely to come into your door if you're not advertising yourself as a local connective tissue guy. And so you really can just individualize within the context of what you would typically do with your patients.
Another question as well is do you sometimes see a correlation between patients who are typically self-manipulating their C-spine and this condition?
Super interesting question. And actually, so a friend of mine sees her patients exclusively online and works exclusively with hypermobile population. And she will emphasize neck manipulation for us clinicians as strictly contraindicated all the time. She's working with all of her patients remotely, so she doesn't have the weird experiences that I have with like very counterintuitive responses to neck manipulation. So I think this is another case where I would treat it much like the general population. Like if it's becoming a very habitual, if it's becoming maladaptive, then we'll work on reeling that in. But a lot of them know that they don't have a good sense of when they do and don't respond well to it. And so a lot of them will avoid self-manipulation anyway. I just don't see it a lot. Most of them know their neck is relatively sensitive to that.
Yeah. The reason I asked is because I had a patient very early on in my career where if I had gone back with this knowledge, it's probable that the patient had a connective tissue disorder of sorts. But it was interesting because that particular patient was, he was aggressively self-manipulating to the point that, it was maladaptive. He was getting symptoms shortly after his self-manipulation. He was like a crack addict, literally. He would adjust, he would get momentary relief and then a severe migraine. Consequently, like it was just a terrible cycle of events. So
and that's the person where you can really frame it as you already are hypermobile. We need to work on stability here, and working on that conditioning, working on that strength, whatever sort of words resonate with them. You can say, hey, we can get you this same feeling, that because all they're doing when they self-manipulate is seeking proprioception. It's just sensory seeking behavior. And so we can tell them like there are other ways of getting this job done, getting the same feeling. It won't be the totally same experience, but the long-term effect is going to be a lot more beneficial. And so definitely that's a good thing to emphasize for those patients. And it's actually quite true that people with hypermobile joints do tend to be constantly stretching their necks, constantly self-manipulating, and it often doesn't take very much either. And they can, yeah, it's funny reflecting back on chiropractic school and practicing on each other. Explains why I got headaches a lot.
Oh man, you poor guy. That's terrible.
Fortunately, I was not one of the highly labile people, and I was quite active myself as a baseline.
Yeah.
Incidentally, we do tend to, well, so more important one to note here is that in the setting of GI disorders and allergy disorders, there seems to be an increased self-manipulation behavior around flare-ups. And so when those joints are at their most sensitive, seems to be when patients get into that cycle the most. And probably because those joints get crunchy when there's chronic low-grade inflammation going on. Yeah, there's some interesting speculation to be done around that for sure.
Yeah, very interesting. This is you've opened a window on I think an important subset of patients that a lot of us have seen, perhaps unbeknownst to us, that have been struggling with this condition, with the connective tissue disorders. So thank you for this, Brendan.
Yeah, totally. And I mean, I know from working with all of you, your instincts are right. You're conservative with these patients. You emphasize fitness with these patients, and being able to, as you know, give a good diagnosis really helps patients to buy into your expertise, your ability to create a prognosis and a plan. It really helps them buy into the ideas that you're putting forth to them, that like strengthening will help you, activity will help you. This can be calmed. So there's really a lot of opportunity in just having some baseline knowledge in there.
Fantastic. Brendan, thank you so much for joining us today. Thank you everyone for your participation, and we'll see you guys on the next one.
Thanks so much.
Thanks, Brendan. Cheers.
Thank you. Thanks, Brendan.